Hello, everyone, and welcome to the TRSP Webinar Series. And I'm delighted to present the latest in our webinars today on the immune system and psychosis. My name's Julia Lappin. I'm a clinical psychiatrist and have been working with people with psychosis for over 20 years, both as a clinician and as a researcher. We'll just start off with an acknowledgement of country and of lived experience. I acknowledge the strength and resilience of Aboriginal and Torres Strait Islander people who are the traditional custodians of the diverse countries from which we're joining this meeting. I'm privileged to be calling from the land of the Gadigal people of the Eora Nation. I pay my respects to elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander people present today. I also acknowledge people with lived experience of mental ill health and recovery and the experience of people who have been carers, families, or supporters. So welcome to the Mindgardens Tertiary Referral Service for Psychosis Seminar Series. The TRSP is a New South Wales Health funded statewide service which is hosted by South East Sydney Local Health District. And we're very grateful to CESLED and New South Wales Health and to the Mindgardens Neuroscience Network for their ongoing support of TRSP. Here at TRSP, we aim to improve lives of people living with complex psychosis and do so through the delivery of our clinical service and also through education and training programs aimed at developing a community of practice for clinicians working with people living with psychosis in order to build capacity. And this webinar series is an example of that capacity building. So just a little bit of housekeeping before I introduce our speaker. As a participant in the webinar, you can write your question in the Q&A, but you can't speak or be seen. There will be a simple anonymous poll at the end of the webinar when you exit, so please complete it so that we know how worthwhile the event was and topics that you'd value for future events. You can also send us feedback by email. Finally, this event is recorded and we'll distribute a link to the event video within 2 weeks to those who have provided us with an email address. You can opt out of our communications at any time with a return email with unsubscribe in the subject line. So turning now to today's talk, I'm delighted to introduce my friend and colleague, Nicola Warren, who's a neuropsychiatrist, director of training and psychiatry course coordinator at the University of Queensland. Nicola is the chair of the RANZCP Committee for Research, and following her PhD has continued to conduct research within psychoneuroimmunology. In 2018, Nicola established the Neuropsychiatric Service at Metro South Addiction and Mental Health Services in Queensland, focusing on the psychiatric care of those with severe movement disorders, epilepsy, and autoimmune encephalitis. She completed her PhD in psychiatric clinical decision-making in anti-NMDAR encephalitis and has been an international and national invited speaker in the area of autoimmune encephalitis. Nicola was awarded the Australian Fellowship to the World Psychiatric Association 2020 and the Royal Australian and New Zealand College of Psychiatrists Early Career Psychiatrist in 2019. So Nicola, really looking forward to your talk today, and I'll hand over to you.
Thank you so much, Julia, for that. I'll just like to acknowledge that I'm speaking on Turrbal and Yagara land in Meanjin in Brisbane today, which is very wet and rainy for a change. So thank you so much for inviting me to talk about the immune system and psychosis, but really focusing on more of the practical aspects of that, which we can relate to our consumers that we see every day, rather than sort of more some of the research aspects of it. And I really wanted to frame today's presentation as in the idea of a case of Annie, who this is an imagined case. Annie is seen in the community mental health clinic, and about 12 months ago, she was diagnosed with schizophrenia. She's had a fairly atypical presentation because she's got quite early treatment resistance, and she has some other atypical features, such as a fairly rapid onset of positive psychotic symptoms, and some more unusual psychotic symptoms, such as visual and tactile perceptual phenomena. And Annie's concerned that she's not getting better, and that something else is going on. And in fact, the team's getting pretty concerned that maybe they've missed something, and the family are concerned for Annie that things aren't going well. They had heard about immune causes of psychosis, and they noted that there's quite a strong family history of immune disorders, and they wondered, is there an immune cause? I frame this question like this because that's often the type of second opinion kind of case that I get called in to do is there an immune cause for this presentation of psychosis? Now, if you're like me and don't remember a lot of your immune system and always found it quite complicated anyway, I think for this presentation, really what you need to know is that there is an innate immune system, which is there all the time. It works straight away. And there's an adaptive immune system, which is a slower to work, but more specific immune system. And there's these things called cytokines or inflammatory proteins that regulate and coordinate both the innate and the adaptive immune system. But that really works in the periphery of our bodies, in the blood. And our brain is kind of special, particularly because of these astrocytes here, which form with their perivascular feet the blood-brain barrier. And that stops large inflammatory proteins that are in the blood crossing over to the brain or the CSF. Now, we used to think this blood-brain barrier meant that there was nothing that crossed over and the brain was an immune privileged organ. But we now know that to be incorrect. And there's a few ways that the peripheral immune system can impact the central immune system. The first is really when you have a leaky blood-brain barrier. And so because of increased diffusion or increased permeability, the larger immune proteins can cross over into the CSF. And the second is when small immune proteins get facilitated to diffuse across the blood-brain barrier, and then they, inside the CNS, produce their own inflammation. And this is called intrathecal inflammation. Now, there are two other ways that we're not going to really focus on today, and that's when peripheral inflammation can affect nerves that impact centrally, and the gut's role in the nervous system. But as I said, we're not going to focus on those today. So that's really the primer of the immune system to follow the rest of the presentation today. So when I think of, is there an immune cause of psychosis? The kind of things I think of are things like thyroid antibody encephalopathy or SLE, neuropsychiatric lupus. And these are usually pretty overt and easy to identify because someone usually has a pre-existing history of thyroid disease or SLE. They might have renal or arthritis complications of such. The one that is more complicated to differentiate is autoimmune encephalitis. Autoimmune encephalitis encompasses a group of disorders where antibodies are developed by the body that target neurons. There's lots of different neurons, lots of different proteins on neurons. And so consequently, there's lots of different autoimmune encephalitides. And these are sort of classified as either impacting proteins on the cell surface or inside the cell. And as I said, there's lots of different cell surface proteins and intracellular proteins that can be impacted. They have complicated, difficult to remember names, but a subsection of these autoimmune encephalitides impact psychiatry more often. These are an emerging group of disorders in that we've really only known about them for the last 10 to 20 years or so, particularly the cell surface protein encephalitis. And for the most part, they don't present to us. They present to neurology or emergency and go into ICU because they present with a rapid onset of seizures and sometimes abnormal neurological symptoms like differences in movement and sensational pain, often associated with confusion, clouding of consciousness, and cognitive deficits, and many times associated with different cancers. So most of them are paraneoplastic. And the typical type of treatment is with steroids or what's called an IVIG or immune modulating treatments like rituximab. As I said, there's a subset of autoimmune encephalitis that are colored here in bright pink, and these tend to affect the limbic structures of the brain more frequently. We're pretty interested in the limbic system. We know that limbic areas are associated with anxiety, mood disturbance, impulsivity, and make up that a part of the hypothesis for psychotic symptoms. These are subdefined as autoimmune limbic encephalitis. And we take it so seriously that at the moment, our schizophrenia guidelines recommend that there is universal antibody screening. So everybody with first episode psychosis has 3 of these encephalitides, NMDA, VGKC, and GAD, tested every time someone presents for the first time. I think this is pretty impressive. If you note, these guidelines are from 2016. We only just knew about these group of disorders at that time, with NMDA really first reported in 2007 and really being tested, particularly in Australia, around 2011. And so we were in Australia and New Zealand really right off the bat with considering these presentations in psychiatry. But there has been a lot of change since 2016. And really that's what I wanted to cover, is really examining the utility of assessing these antibodies in everybody who presents with first episode psychosis. So I'll go in reverse order, looking at GAD first. Many people have heard about GAD antibodies more recently because Celine Dion's reported to have stiff person syndrome, which is a GAD antibody-mediated disorder that presents with neurological symptoms. And for the most part, GAD antibodies are associated with a range of neurological disorders that are seizures or movement disturbance. GAD can also be antibodies can also be seen in type 1 diabetes, in autoimmune thyroid disease, and a range of other autoimmune conditions like celiac and antiphospholipid syndrome. GAD encephalitis most typically presents with seizures, often with some cognitive deficits and often with some mood changes that go along with it. But it's in our guidelines for first episode psychosis, and we really wanted to know how frequently was GAD encephalitis presenting with psychosis. So we looked at all of the studies which screened for GAD antibodies in people with first episode and schizophrenia spectrum disorders, noting that overall, it's pretty uncommon to get antibodies in both people with psychosis and in the general population. And when you compare people with psychosis compared to those in the healthy controls, it's no more frequent in psychosis. And when you specifically looked at the 2,700 or so people who had GAD antibodies in first episode psychosis, when you went on to sort of look in more depth in these papers, none of those cases had encephalitis. They were all incidental GAD antibody findings. But I suppose with something that is rare, there's the potential to miss cases when you look, when you do meta-analyses. And you're only looking here at a bit under 3,000 people. So then we looked at every case of GAD encephalitis ever published. And at that time, there was 346 cases of GAD encephalitis published in the literature, and about 15 of those had some sort of psychotic symptoms in their clinical presentation. By and large, those psychotic symptoms were associated with seizures and were sort of periictal psychosis. But in 5 cases, the presentation was initially with psychosis without any overt neurology at the initial presentation. So 5 cases ever published of psychosis presenting to psychiatric services. But when you looked further at those cases, all had non-psychiatric features that most of us would identify through clinical examination or screening criteria that would alert us to this being not someone with a primary psychotic disorder, as something else going on. And when I say the clinical screening criteria, there are 2 clinical screening criteria that have been proposed in the literature. One by James Scott in Queensland and colleagues, and one from Germany by Höken and Preuss. And these clinical screening criteria have a range of clinical symptoms that try to identify high-risk presentations where you should test for these antibodies. So if you look at the Scott criteria, things like having neurological symptoms at the time of presentation, having very severe cognitive involvement, catatonia or intermittent agitation or excitatory states, having very heightened sensitivity to antipsychotics, or needing ECT because of early illness severity. The Höken and Preuss clinical screening criteria are probably less relevant for the Australian-New Zealand context, just because most of the time when somebody has seizures or decreased level of consciousness, they're not going to stay in psychiatry anyway. And also when you're testing for a CSF or looking at other things in the CSF, you're almost always testing for antibodies in the Australian context anyway. So there's these clinical screening criteria, and when you apply them to the cases of GAD encephalitis that presented with psychosis to psychiatric services, they picked up all the cases. There's a few other things to consider with GAD antibodies. Titer really matters with GAD antibodies in that although you may get a response from the lab saying this person's got elevated GAD antibodies, it's not usually considered to be encephalitis unless it's in the thousands. And that's really because of this guy again, the astrocyte and the blood-brain barrier, because just having the antibodies in the serum doesn't necessarily mean that you've got autoimmune encephalitis. You really need to have that intrathecal antibody synthesis. So again, the serum is separate from the CSF. And so it's not just a case of having a leaky blood-brain barrier and having a low titer of antibodies cross over into the serum. It is about having immune-mediated development of antibodies in the CSF that actually is associated with encephalitis. So to summarize GAD and psychosis, GAD is a rare to very rare association with psychosis, and therefore testing everybody with first episode psychosis isn't supported by more recent evidence. And instead, we would recommend you use your normal clinical acumen to determine who is going to be more likely to, who's not presenting with a primary psychotic presentation. And you can use a clinical screening tool to help that assessment. And if you've identified someone and thought, okay, they need serum testing, If you're concerned about encephalitis, you need to go further and do CSF testing as well to demonstrate the antibody in the CSF. So moving on to VGKC. Similar to GAD, VGKC-associated syndromes most frequently presents with seizures and can present with another type of presentation called peripheral nerve hyperexcitability or Morvan syndrome. Limbic encephalitis tends to be a bit more common than with GAD, most often presenting with seizures and cognitive deficit, but also interestingly, often with quite severe sleep disturbance. And the psychiatric symptoms, including psychosis, tend to be a bit more common than with GAD. But again, similar to GAD, titer does matter in that it will be called a positive titer by most labs when it's over 85. Some labs are a bit more specific and call it when it's over 100, but it really doesn't cause encephalitis unless it's a high positive titer over about 300. So a narrower range than GAD, but it does leave that problem of what do you do with these low positive titer cases in between 85 and 300. The other thing that has occurred is that following our use of the guidelines and the sort of general recognition of VGKC, which happens with emerging disorders, is that it was recognized that it wasn't really VGKC causing the encephalitis. It's actually two proteins on either side of the VGKC antibody, where you can either get an LGI1 encephalitis or a Caspar-2 encephalitis. So when this was identified, people went back and retested all of their high positive VGKC cases and found out that everybody either had LGI1 or Caspar-2 antibodies. And it was actually these antibodies causing the encephalitis, not VGKC. And in fact, there's been some rare cases of LGI1 or Caspar-2 encephalitis with no VGKC titer. And we reported on one case of Caspar-2 that presented with a postpartum psychosis with no VGKC titer. So it leaves us with this question of, we've been testing a lot of people with VGKC. What does it really mean if you've got a positive but a low positive VGKC titer and you don't have these Caspar-2 LGI1 antibodies? We looked at this with all of our Queensland testing. So Queensland Pathology is a reference lab for a lot of the eastern states, and they'd done around 30,000 tests for VGKC up until 2019. 2019 with this publication. We only had ethics to look at the test that was for public psychiatry, of which about 4,000 had been completed in public psychiatry over 9 years. So within that time, there were 2 cases which had a high positive VGKC titer, and both of those cases had LGI1. And both of those cases, although they initially presented to psychiatry, they were very quickly identified as being something else going on, either through seizures or focal neurological symptoms, and they had other abnormalities on paraclinical tests like EEG and MRI. And they were definitely picked up by clinical screening criteria. We had 12 cases over that time of this low positive VGKC. None of them had LGI1 or Caspar-2 positivity. None of them had focal neurology or seizures, and none of them had abnormal investigations like MRI or EEG. And when these cases were followed up for a mean of 2.5 years, they all retained their original presenting diagnosis, mostly of schizophrenia. So for us, that was quite reassuring that if you have cases of low positive VGKC without Caspar-2 LGI1 antibodies, long-term assessment doesn't demonstrate encephalitis. We still think you should investigate and you should still do the MRIs and do the EEG and continue to follow up, but don't delay psychiatric treatment, because one of the other things we found was that this group of patients tended to have a much longer length of stay than what is the average for Queensland patients. And anecdotally, we saw patients sitting in hospital, waiting for neurology to review, waiting for tests to come back, for the lumbar puncture, for the MRI. And in that time, you're often not treating the psychotic symptoms. People can be very distressed, and it can be really confusing for both patients and family. So to summarize VGKC and psychosis, it's uncommon, but it does occur, but not to the extent which would suggest that universal antibody screening is supported by evidence. And again, we recommend using your clinical acumen and possibly clinical screening tools to determine which cases need Caspar-2 LGI1 testing and which cases need to go on to have lumbar puncture. Okay, finally on to NMDA. Saving the best for last, with NMDA being by far and away the most common autoimmune encephalitis, and also the most common autoimmune encephalitis that presents with psychiatric symptoms. NMDA can present at any age, and cases have been reported from birth to 85 years, but is most common in the 20s and around adolescence to the early 20s. It is 4 times more common in females. Now, NMDA can be associated with ovarian teratoma, where initial presentations of the initial reports, of NMDA reported teratoma in about 70% of cases. More recent studies and sort of retrospective look of NMDA shows that it's only about 30%. However, even when we exclude those cases, NMDA is still more common in females, perhaps reflective of higher rates of autoimmunity in females anyway. This is the NMDA receptor, which we actually know quite a lot about because this is where ketamine and PCP binds. It's a glutamate receptor. And NMDA binds to one side of the receptor. And what happens is it cross-links with the receptor. It's internalized and destroyed. And I'm saying that for a particular reason because it's thought that that is one of the reasons why you don't get a lot of overt inflammation, particularly on neuroimaging, where for the majority of cases, there will not be any MRI findings and certainly not any CT findings for NMDA, which is only abnormal, MRI findings seen in about 30% of cases. What is much more common is to see an abnormal EEG, but it's non-specific. So it then generally shows diffuse slow waves, which is seen in encephalopathy. What is thought to happen with NMDA is that NMDA normally tonically inhibits dopamine in the mesolimbic pathways. And so without NMDA inhibiting the mesolimbic dopamine, you get dysregulation of that dopamine. And we know dysregulated dopamine in the mesolimbic area is thought to increase the likelihood of psychosis, and that's part of our dopaminergic hypothesis of schizophrenia. The NMDA also works in the prefrontal circuits. And so not only do you get this dysregulated dopamine causing sort of positive psychotic symptoms, you don't get that prefrontal checking of the positive psychotic symptoms and tend to get a range of other sort of psychiatric symptoms. So it's unsurprising that 70 to 80% of people with NMDA encephalitis present to psychiatric services. There's no pathognomonic symptom of NMDA. There's no specific feature that you can see that and go, oh, okay, that must be NMDA. But there does tend to be sort of a particular cluster of symptoms and a pattern of presentation. People present with a really rapid onset of most commonly severe agitation. They often have associated problems with their speech, and that can range from dysarthria to mutism. And there's a high rates of cognitive deficits as well. And this is much more than would be expected for a primary psychotic disorder at this initial presentation. So really high rates of memory deficits in particular. We see much higher rates of catatonia occurring in between 40 to 60% of cases, and often this is fluctuating. What's described in the literature is light bulb catatonia, where someone can go from that withdrawn, mute, not moving, sometimes motor stuck type catatonia, and in a moment switch to that hyperexcitable, agitated, a frenetic type of catatonia. There's also a high rate of mood and anxiety lability with the psychiatric symptoms. What's important to highlight is that when you look at everybody with NMDA, it's not just psychosis. About 40% of people with NMDA never have delusions, hallucinations, or thought disorder. They may present with a more mood predominant presentation. But rapid identification is really important. We know that the faster you can get immune modulation type treatments in, the better the outcome, and particularly the better the psychiatric outcome, which tends to be a bit slower to resolve with immune modulation. Delayed treatment can be associated with long-term cognitive deficits, as well as things like fatigue and anxiety. You also want to identify NMDA early because there's a concern that you'll get this extra sensitivity to antipsychotics with higher rates of neuroleptic malignant syndrome seen. You may also want to identify it early because catatonia is a very prominent feature. Often we treat catatonia with ECT or benzodiazepines, and people with NMDA may not tolerate ECT and benzodiazepines in the same way, particularly because of autonomic symptoms that tend to go along with NMDA encephalitis. So you might think, well, it could be very easy to identify NMDA because most people with NMDA have neurological symptoms, and we're pretty good at picking up when that occurs. The challenge is that there tends to be a delay, a real lag of time between when people initially present with psychiatric symptoms to when they develop neurological symptoms, and that's usually around 2 to 3 weeks later. The other thing can be is the neurological symptoms can be subtle, like orofacial dyskinesia, may actually look like a lot of our extrapyramidal symptoms. So orofacial dyskinesia looks like tardive dyskinesia. And in fact, one case in Queensland was picked up in the last few years because an intern was noticing a patient who just presented with psychosis and had only been on antipsychotics for 2 days, developed what they thought was tardive dyskinesia, and sort of questioned this, and then they got further testing and saw that it was actually NMDA. But often the neurological symptoms might not be as overt as in some of the other autoimmune encephalitis. So we need to look for the antibody, and ideally, you can't get NMDA from antibodies just in the serum. The antibody has to be here in the CSF. We can't lumbar puncture every patient that comes into psychiatry. And so we look at the serum antibodies. But there's a problem with that process because over time we've realized that this really is just not very common. So, and this is, unfortunately, I haven't put in the sort of the larger, more recent studies, which show that we really don't pick up NMDA antibodies very frequently. And so maybe clinical screening can be really helpful in this situation, where we can identify people who have a much higher probability of having NMDA, and that can, instead of screening everybody for the antibody, direct us to who to test the antibody in. And in fact, when you retrospectively look at all the cases ever published in the literature, and as well as our Queensland cohort, you find that these screening criteria are quite sensitive, although not massively specific. They can at least identify who to target the testing in. And it works for not just presentations of psychosis, it works for all psychiatric presentations, and it works before the neurological symptoms are present. One of the challenges with NMDA is that you may look for the antibodies in the serum, and if they're there, you then go to test the CSF. And not all cases of NMDA have the antibodies in the CSF. And there was this question of what does that mean? Some people said that this is a false positive and that it doesn't mean that it's encephalitis, but there was questions about this, particularly from the Oxford group, which is one of the sort of leaders in autoimmune encephalitis in the UK. So we looked at our cases in Queensland, and we found that a third of the time when people had NMDA antibodies identified, they just had them in the serum and they didn't have them in the CSF. And when you looked at these cases over the long term, they don't develop neurological symptoms. They don't improve. In the few cases that we had, 2 cases that we tried immune therapy with, neither improved. And they all improve with traditional psychiatric care. In comparison to the other cases where the antibody was in the CSF, who all deteriorate rather rapidly and have quite a severe presentation and don't improve with traditional psychiatric care and only improve when there's immune therapy. When you look at immune therapy, you get 80% achieve complete to near complete recovery, with most people responding to immune therapy. And in comparison, our 2 cases had no response when there wasn't the antibody in the CSF. But this is talking about really small numbers. There's only, as far as I'm aware, another 8 cases from the UK that CSF antibody negative has been tried with immune therapy, all of which didn't have any response. So you're talking about 12 cases in total where immune therapy has been tried. 10 cases, can't do my math, in total where antibody's been tried. There is some reluctance to say definitively that this is when the antibody isn't in the CSF, you can just ignore it completely. But for the most part, a watch and wait type approach is appropriate. So to summarize NMDA antibodies, it's uncommon, but it's an important differential to consider for psychosis, and probably universal antibody screening isn't warranted. The reason why I'm less definitive around that, I think, relates to my own anxiety, in that I fear if we take it out of the recommendations for everybody, do we risk people just forgetting about this altogether and not testing when it is appropriate? And I think we really need to remember our clinical acumen and use these clinical screening tools to identify cases that need CSF analysis. So if we go back to the case of Annie, Annie, who presented with this early treatment resistance and atypical kind of presentation, she clinically suggests that something else might be going on. And so she clinically screens positive using the screening tool. And so she has her serum antibodies done, which show an antibody in the serum. She then goes to have a lumbar puncture and doesn't show the antibody in the CSF. So by and large, we can suggest that she doesn't have NMDA encephalitis because she doesn't have the antibody in the CSF. And we should consider just treating this as a primary psychotic disorder. But what is noted when the CSF is assessed is that the CSF isn't normal. What do I mean by that? Is that she's got some elevated protein in her CSF. and she's got some oligoclonal bands. This kind of pattern isn't unusual for someone with a primary psychotic disorder. When we, again, did a meta-analysis of people with schizophrenia spectrum disorders, you find that people with schizophrenia spectrum disorders have increased blood-brain barrier permeability with evident by albumin ratio or increased total protein in their CSF more frequently than healthy controls, so that they've got leaky blood-brain barriers. And unfortunately, studies with controls weren't large enough to do meta-analysis, but there's certainly a percentage of cases of people with schizophrenia spectrum disorders that have oligoclonal bands and high rates of IgG in their CSF, which is a marker of active inflammation. So they've got this immune cells that are producing inflammatory cells within the central nervous system. They've also got higher rates of cytokines in the CSF, particularly IL-6 and IL-8. And as you may remember, the cytokines are these inflammatory proteins that help regulate the innate and the adaptive immune system. And so they've got a disbalance of cytokines. And it's postulated that that can have quite a lot of impact on the central nervous system, changing the way the nerve cells move, changing the way the nerve cells interact, and changing the glial cells that support the neurons. There seems to be a difference as well, depending on the stage of the psychotic disorder. This wonderful publication by one of my colleagues who wrote this as he was a medical student at this time, published in Lancet, noted that there is a difference in the type of cytokines compared in the acute phases of schizophrenia compared to the chronic phases, which doesn't come as a massive surprise. We know that when we look at genome-wide association studies, there are shared genes that regulate the immune system as well as the risk of schizophrenia. We know that people with psychotic disorders have higher risk of autoimmune disorders and vice versa. And it's postulated that the immune system is what mediates that the increased risk of schizophrenia in people with pre and perinatal infections, as well as that early exposure to stress. The immune system is the sort of the mediator of those effects. But how does it actually affect Annie, who has elevated protein and oligoclonal bands? Well, and this is still in the research phase, that there is some support for looking at adjuvant anti-inflammatories for people with schizophrenia spectrum disorders, particularly things like aspirin, minocycline, although when the studies are pulled together in meta-analyses, the clinical difference isn't entirely clear. And it sort of makes me think maybe that's because we're not targeting, or those studies haven't necessarily targeted the right type of people, where not everyone with schizophrenia has an inflammatory signature. There's a small percentage of people who have that inflammatory signature in their CSF. And in fact, that's what some more recent studies are doing, is they're identifying people who have that inflammatory signature and are either using anti-inflammatories or immune modulators. And my colleagues in Germany are running a trial at the moment looking at rituximab, particularly for people with inflammatory signatures in schizophrenia. I find very interesting when we take this perspective to things that we've known about for a long time. We all use clozapine every day, and we know clozapine has an impact on the immune system in that it induces fever. It obviously affects neutrophils and lymphocytes, and it has a higher risk of immunological adverse effects like myocarditis and hepatitis. But some of the hypothesis around that is that cytokine really clozapine impacts cytokine productions, thought to inhibit pro-inflammatory cytokines and increase adaptive immune system cytokines. And there is this hypothesis that that's one of the mechanisms of action for clozapine. So where does that actually bring us? If we imagine Annie, who's presented with this atypical presentation of psychosis, it's important to really go back to our roots. We're good at assessing what primary psychotic disorders are. We know what that looks like, and we know when something is not consistent with a primary psychotic disorder. And we can certainly use clinical screening tools to help us identify who needs to have antibodies assessed, particularly in their serum. And so when we assess those antibodies, if they're negative, we should continue on with treatment as usual. But if they're positive, we should progress to look at people's, do a lumbar puncture and look at CSF. At the moment, when CSF antibodies are not present, although you should continue to consider this and certainly discuss with neurology colleagues, on the whole, treatment as usual is the recommended option. Whereas when antibodies are demonstrated, it indicates there's an encephalitis and immune therapy needs to be considered. But I do wonder whether in the future, when we consider a subgroup of people who have inflammatory pictures in their CSF, whether there might be evidence to say you need to use specific antipsychotics like clozapine, or there's a role for anti-inflammatories or immune modulator therapy, which I think overall is quite a positive and hopeful thing, in that I think sometimes you can get stuck in particularly schizophrenia research, which doesn't tend to show a lot of new findings very frequently, and whether there is some time in the future where we'll be able to more personalize and individualize particular treatments. So that's me. Thank you so very much for listening today. I'll be really happy to answer any of your questions after this, and I will put these other slides on, Julia, as you talk about the next webinar.
Thanks so much, Nicola. That was a really fantastic talk, and you've really covered all the key points that are relevant to the discussion around the immune system and psychosis. So thank you so much for a really comprehensive talk. I really felt that it was just wonderful. So thank you. While we have a few minutes, while people, if you have questions for Nicola, pop them into the Q&A, please. Just while you're writing those, I'll just highlight the details of the webinar for next month. And we have Professor Sharon Lohan talking to us about smoking cessation in severe mental illness. And this topic was actually one of those that were selected by the audience from previous webinars as being one that people were really keen to have covered as a topic, and that's why we've included it. And Sharon's a real expert in Australia on this topic. And there's just two other slides, Nicola, if we'll just move through those. Yes, it was just to say that if you have any queries about the TRSP, whether it's about the clinical service or more broadly our capacity building and training and education, that's our contact details. And finally, we're hosted by Mindgardens Neuroscience Network, and these are the contact details for Mindgardens. Thanks, everyone. So we might just stop sharing the slides, and then we can go to gallery. And Nicola, we've got a few questions coming in from the chat, but just to frame the key change in guidance that has emerged over the past sort of decade, really. In the last version of the Australian and New Zealand guidelines for treatment of schizophrenia, it was recommended, based on evidence that we had at that time, that we should be screening everybody. And what you're presenting today is really evidence to the contrary now. We've got slightly more studies have come in. It looks as if the prevalence is quite low. And you're saying, essentially, rely on clinical acumen, but if you have a high index of suspicion, do the serum test. Yeah. And then, can you just clarify, is it only if that's positive that we go to a CSF?
I think that's a really good question, and it is a little tricky. And I think that's when you need to work with your neurology colleagues quite closely, making decisions around that. And certainly, I just want to highlight that I'm not in any way criticising the 2016 guidelines. I think, Australia was really leading the world really in that area, because we've only just realised, and the initial studies were probably screening where we saw much higher rates of about 5% of people with antibodies demonstrated. They were probably from more abnormal cases that people had already identified as being the atypical type cases. So it kind of clouded the view of how prevalent this is. And so that's why, with sort of that longer term and our increasing awareness of it, we've realized it's just not as common. And also just the increased confidence that you can pick this up through what we do best, which is just assessing people and taking a really good history and doing an examination. When I've sort of varied over time in that you have to demonstrate the antibody to be in the CSF to call it encephalitis. Yes. And yes, you could just go straight to lumbar puncture, but that still means that you would be lumbar puncturing a lot of people. And in most Australian services, that's just not practical. So when I talk to my German colleagues who do lumbar puncture for everybody who comes in with psychosis, they say, this is an assurance, absolutely everyone needs it. It's just not practical in Australia. And I think the majority of people who have the antibody in the serum will have it also in the CSF, and so it's best to go through that process. There is a very small percentage in our initial studies where I looked at every case of NMDA ever published in the literature. Around 10% of cases showed the antibody in the CSF and not in the serum. And so there was that initial concern, maybe we'll miss people.
Yes.
And in preparing for this presentation and others more recently, I got very anxious about that and went back and had a look at all those cases. And in fact, the majority of those cases are people who present with seizures and with epilepsy and non-psychiatric symptoms.
So we're not going to miss people with.
So I think it is reassuring that we're not going to miss people. But in saying that, if you've got someone who clinically does not look like they've got schizophrenia, they've got all these symptoms that are very suggestive of something organic going on, they've got catatonia, they've got a really rapid, really severe presentation, the antibody is not there in the serum, I think it is still wise to then still have that conversation with your neurology colleagues and say, look, I still think they need a lumbar puncture in that situation. It just helps the clinical decision making. This is still a clinical diagnosis. It's not a diagnosis just based on a test. But I think my experience talking with neurology colleagues, they're helped by us saying, these are the reasons I don't think it's schizophrenia, because of rapid presentation, all of these. And I've used a clinical screening tool and they test positive. This is why I think they need a lumbar puncture. What I find often in that communication, where communication goes wrong, is when we just say, can you come see the patient? And neurologists don't know what that sort of
No.
means. And they say, well, the antibody's negative. No, we're not going to. So it's really explaining our thinking of why we think.
You've got a high index of suspicion this is atypical.
Yeah.
Yeah. Brilliant. That's really helpful, Nicola, and helpful to hear that really it's relying on the clinical acumen really primarily in these cases.
Yeah.
Now, I've got a few questions coming through for you. I'll start with one from Nick Burns, who's our lead for rehab psychiatry in RANZ in New South Wales. Can autoimmune encephalitis present with tics amongst other symptoms or other movement disorders? And he notes that you've covered catatonia in your presentation.
Yeah. In particular, so NMDA can present with just movement symptoms, where 70 to 80% present primarily with psychiatric symptoms. That still leaves 30 to 20%, 20 to 30% presenting with movement symptoms. And often that is with movement disorders. Most frequently, that is perioral movement disorders. And so it does tend to look like tic type presentations.
Okay, that's really helpful.
Certainly cases that have been reported where there was the thought that this was tics, particularly in young females, which NMDA tends to be more common in itself. And then also that's a particularly common time where you get tics as well, demographics, sorry, that you get tics as well. And so, yes, it certainly can, less common than the psychiatric type presentation. And often it has that similar type of deterioration, so that it will present with movement symptoms for a few weeks, but then it'll get worse and worse and worse.
Yeah.
And often involve sort of the clouding of consciousness, worse movement, seizures, autonomic dysfunction as well.
Wonderful. Thanks for that. And someone else has asked, is there comorbidity between psychosis and autoimmune disorders? Is it due to shared inflammatory markers?
I think the easy answer is that no one really knows the answer to that. So as I noted, there is genetic evidence to say that there is a higher rate, a connection between psychosis and autoimmunity. So if you look at GWAS, and when people have done studies on those, people with schizophrenia tend to have higher rates of immune disorders, genetics for immune disorders. There also tends to be a range of sort of biological reasons explaining the comorbidity. The studies that look just at sort of more common inflammatory markers like ESR, CRP, don't tend to show large differences, particularly when you look at meta-analyses compared to healthy controls. And that's why I suppose looking at sort of the cytokines, which are the more sort of specific inflammatory markers. But it's not everybody. It's not everybody with schizophrenia will have higher rates of cytokines or have that sort of inflammatory picture.
No, and again, this is why towards the end you're talking about personalized medicine, tailored approach, so that perhaps there's a subset of people who have an autoimmune component to their pathology. And
we're not there yet.
No, we're not there yet.
We're moving in that direction. I'd like to be hopeful to suggest that we're moving in that direction, and that for a percentage, and it's probably a small percentage realistically, that we could change and as I said, individualize the way we look at their treatment.
Yeah, so keeping a high index of suspicion, remembering to think of these things, but to follow this sort of path of assessment procedures that you've outlined so clearly in the talk. Nicola, we're gonna have to draw it to a close because we're nearly time up. Well, I'm just going to answer one more question. Is it possible for the slides to be shared? We will post the recording of Nicola's webinar on our TRSP website, and that should be available within a couple of talks. If there are any additional questions that you have for Nicola, please send them through and we'll ask Nicola to respond to them, and we'll post those to anyone who's registered and included their email and indicated that they're interested to receive that. So just before we close, I'd just like to thank Nicola again for a fantastic talk on a really emerging area, and thank you, Nicola, for joining us on what turns out to be a holiday in Queensland. So we're very grateful. Thanks so much.
No
Bye,
worries.
everyone.
Thank you.
Bye.